invited to speak at such a lovely event, and really such a great opportunity for myself as a clinical doctor to engage with this kind of research. I really enjoy doing this research, and I hope that you can enjoy this presentation as well. So as I said, I'm a specialist physician and I'm an advocate for lifestyle medicine from the South African Lifestyle Medicine Association. Okay. Right, so in our talk today, we're going to present the impact of climate inequality, specifically here in South Africa. We're also going to describe the South African health landscape and the quadruple burden of disease. Then we'll explore how the direct health risks of climate change are actually considered a threat multiplier to this health situation that we have. We'll also discuss climate change as a threat to lifestyle medicine, and I'll go into defining what planetary health is as a solution towards the challenges of lifestyle medicine, and explore a really nice case study coming from Senegal and how they addressed schistosomiasis infections using planetary health. In the end, I'm just going to give us a call to action and on how we can involve ourselves in planetary health, and finally give you some practical tips as healthcare professionals on how to prescribe lifestyle medicine for climate change. So this first slide, I think it's just a brief recap as to what climate change is about and how it affects us here in South Africa. Some of the big major weather changes are heat waves, droughts, and heavy rainfall, which all have which all have ripple effects to the health system and life systems in general. So some of our visitors here are coming from outside of Johannesburg today, but I'm a proud Jersey girl, and I just show you here, so I'll just give a little bit of the history of Johannesburg. The area of the Witwatersrand became sort of acknowledged as a city in around the 1882 when they discovered gold mines, and they decided to make a real industry out of the gold mines in Johannesburg. People from Europe and such really developed the industry, where there were set up that mining bosses and such were living in the northern suburbs, where there was a point where there were over 6,000 trees being planted from all over the world in the suburbs for where these mining bosses were supposed to be living. And so, Johannesburg is actually one of the biggest man-made forests in the world. So it's a really amazing thing if you're living in the northern suburbs with this beautiful architecture and trees everywhere. You can almost not see where the houses are in between all the lush green. But the sad truth of the history of South Africa is that at the same time, while we had mining bosses living in luxurious homes, they also needed to create labor for these mines and for these people to come and work in these mines. And so people came from all over South Africa as migrant labor and were placed in peri-suburban places. And so if you don't know if you're not from Joburg, Soweto actually stands for the southwestern townships, and so they created these township areas where people had been displaced through different laws, apartheid laws like the Group Areas Act, and even before that. So why is this important is that if you take a zoom into the streets of these different suburbs, you'll see that the streets of lovely Joburg, we don't have the mountain, but we do have jacarandas. So we get these lovely green shaded roads, and sometimes you can find the difference in temperature can drop between 4 degrees lower in our suburbs compared to in the peri-urban townships, where, as you can see, at that time there were no plans for planting any trees, and so houses are so densely populated that even as you walk along in the streets, there's a lot of dust and there's not a lot of shade, and so the impact of climate change really is quite closely linked to the painful legacy of apartheid that we had in this country. So just to talk then directly on the impacts of climate inequality in this country in terms of risk factors. So urban migration, not only just from the state of poverty that we've expressed, that people are now looking for jobs in the urban areas based on this history that we have, also now the impact of of climate change, in terms of drought, has displaced a lot of people into the urban areas, and therefore experiencing climate in that way. Informal settlements, these are usually poorly planned informal housing with housing often in low-lying areas which are prone to hazards. You know, you'll find houses being built, squatter camps being built directly on swamp land, and if there's any weather event, those people are directly at risk. The limited wash access. So WASH stands for water and sanitation and hygiene access. So with these changes in weather and the displacement of people, we're recognizing that people are actually having inadequate water and sanitation and hygiene facilities, and there is also an increased amount of pollution in these in the water. The historical injustice, as was touched on, it has created such that there is such a legacy that people from African, coloured and Indian communities are not, they're at a disadvantage already in terms of dealing with the impact of climate change. We also recognize that there's a very low adaptive capacity from our government and our infrastructure as it stands. You know, our houses are not built for the cold. Our health systems are not ready for the climate change emergencies that present, and we recognize that there is really very little adaptive capacity, and especially for the poor, to be able to address climate inequality. Of note, and it's actually something that the Department of Health seems to be quite concerned about, is the gender disparities that are associated with climate change. You know, a lot of the time, if women in rural areas cannot provide for their families because there's not good enough weather to support agriculture, they'll then be forced to move into the cities. Or even in some cases, as we know, HIV is a big issue in our country. A lot of people will resort to sexual work in order to provide for their families. So these gender disparities are quite relevant, and it is something that we recognize. And then the last thing I'm going to talk about is urban heat stress. So urban heat stress is basically about, you know, we talk about heat stress, but in urban areas where there is no trees and such like that, you find that there is a lot of heat stress in areas like in the peri-urban area. So I've got a nice diagram here to show you about the urban heat island effect. So if you look at this, I don't know how this pointer works, but number one would be the CBD, Johannesburg CBD area. If you go to number two, that's Alexandra, so opposite, and if you can see, because this is during the daytime, as you can see, really lovely there. Where we know all the trees are in Sandton, right across the road from Alexandra, that redness, that heat effect that you would have had is not the same. And then if you go further to the east, that's Tembisa, and then down here is Soweto. So you're seeing these red, bright lights up, because that is how much heat stress that is experienced in these areas that are in these peri-urban, non-suburban sort of areas. And how this is important is because, as you can see, at night, these colors become much brighter. And we'll talk about this more as we go on to this presentation, but the stress of heat, especially at night, is very important because it affects sleep quality, and sleep essentially is important for all factors of life. So now we move on to just talking about where we are in South Africa. As a medical doctor, I've been practicing now for about 10, 15 years, and you know, South Africa is in a really big stage. You know, we've got what we call the quadruple burden of disease, where we are facing high mortality from 4 different regions. So we talk about infectious diseases, where we're dealing with HIV and AIDS, but also other infections like diarrheal illnesses and vector-borne illnesses, which is really a major cause of morbidity and mortality, with compounding antibiotic resistance, including for TB. This is a major pressure on the health system. The other source of mortality and morbidity we have is high rates of maternal and child mortality. So it's really a sad perspective. Unfortunately, I can't speak too much about that as I'm an adult physician doctor, but it's an important challenge in this country, and The next is the high rates of non-communicable diseases, and this is where we talk a lot around lifestyle medicine. It's a big burden on our health system, and then violence and interpersonal injuries. So we have a major burden of disease in South Africa and a lot of challenge already in this healthcare system. So the storm is on the horizon. We already see the newspaper headlines every single day. There's floods all over the Eastern Cape and KZN. I mean, there's snow in the middle of summer. I mean, I think that happened last year. And people are struggling with heat stroke in areas like the Northern Cape. So it's happening. This is not something that we're talking about as something that is going to happen in the future. We are dealing with climate change right here, right now, and it's affecting our health system. So this next part of the presentation is that I'm going to go into a little bit of detail on exploring the direct health impacts of climate change along these structures. So I'll start with talking about heat-related disease. So I'm just going to go into a little bit of physiology here. So, you know, when we experience heat, the body's natural cardiovascular response is to increase cardiac output and to allow for vasodilation in the skin, to allow for heat to be evaporated through the skin. So that on its own puts a lot of strain on even a healthy heart. You know, your heart rate is already automatically beating faster. So that on its own, just the cardiovascular physiological effects of heat stress are a strain on an individual, and it's then even worse for people with underlying cardiac disease like hypertension. The risk of dehydration is also very important, especially in those on the extremes of age in terms of pediatric and elderly communities, especially when we have heat waves and we don't really have the right public health strategies when we do have heat waves. There's not really a clear information that maybe children shouldn't be playing outside on certain days of weather, or it's just not being safe for people to go outside when it's dark and cooler. So you know, dehydration becomes a big issue, and heat stroke, which is an extreme end of dehydration, is actually something that can be life-threatening and requiring hospital admission. I mentioned here something about increased heart rate variability. This is a physiological condition where, you know, if your heart rate continuously goes up and down, it puts your heart at strain and your body at strain for chronic diseases. So that's another impact of heat stress. And then I put here skin cancer, melanoma, and hyperpigmentation. Very interestingly, I know a lot of us non-Caucasians say, well, we don't need sunscreen. And actually, there is some truth in that. And non-Caucasians, when they get sun exposure, they will not get skin cancer or melanoma, but hyperpigmentation is a real issue, and it is something that is very distressing for a lot of us. And the sun exposure and not wearing SPF is one of those complications of health. Then we talk about vector-borne diseases. So how we can correlate vector-borne diseases and climate change. So from positive things like agriculture, building of dams and irrigation systems, to unintended consequences like flood disasters, all of these have contributed to increased transmission of vector-borne diseases. So I've listed here just 3 of the common ones. So malaria is a parasitic infection which is caused by the Plasmodium species parasite, which is delivered by the Anopheles mosquito. It can range from very minor and very mild disease to severe condition with mental retardation, renal dysfunction, and coma, and even death. Schistosomiasis, I'll go into that a little bit later into our presentation, but this is basically the cause of bilharzia, and it is transmitted via a snail, which can also be found in flooded waters. Rift Valley fever, not actually quite common for us to often diagnose and pick up, but it's a general cause of really non-specific sort of illness where people come in just not well, and I think it's just something, I think, as I put it in there, is not something we talk about all the time, but it's obviously probably something we often miss because of this exposure to vectors. Then the next field space of health impact is waterborne illnesses. So flooding and extreme weather events cause us to displace population, and that leads to contaminated water sources. And that then puts people at risk of these acute gastrointestinal illnesses. And these range from cholera, which is extremely a severe diarrheal disease. If not caught early, it can actually cause can be fatal. Shigellosis, which is caused salmonella and E. coli. All of these, and I'm kind of just stepping away from my notes here after Mafoko's presentation, because you mentioned something about hospitals and the work that we're doing in the hospitals, and all of these conditions, all of these waterborne illnesses are bacterial diarrheas that need antibiotics. And what I'm finding as working in the hospitals is we're finding this overwhelming resistance in the community. You're coming in with patients coming from the community with E. coli infections, which are multi-drug resistant, and you don't even know where to start in terms of what antibiotics to give them. And it's easy when you're in private practice because you can run all the blood cultures, but when you're in the places where these people need this help, access to this kind of antibiotic treatment is just not available, and then subsequently you're getting people admitted to tertiary levels of care, where hand hygiene, I'm telling you, is one of the worst contributors to climate change, because you're throwing away plastic aprons and all of that. So I'm sort of swaying away from that, but essentially the exposure of waterborne illnesses is crossing over all the way to the pressure that climate change is contributing to from the hospitals, and also antibiotic resistance. Air pollutions and respiratory condition. First talk was fantastic, it really just went into that. So I think we actually referenced the same study from the Highveld priority area in Secunda, and they looked at the air pollutant levels on warmer days, and when they say warmer, they say above 15 degrees, and they assessed that actually more people were getting admitted on days with similar air pollutant levels in the air, but when they were warmer days, they were getting more respiratory admissions. So the actual direct impact of not only just the pollution itself, but the direct impact of the heat itself is what's contributing. Also, as a doctor, I'm also recognizing we're getting a lot more admissions but actually into hospital admissions for bronchitis, asthma, cough, lots of upper respiratory conditions, pneumonia and wheezing, which is really, people that aren't from Johannesburg and then move up to here will always be able to tell you chalk and cheese how their respiratory conditions had changed. Mental health deserves a slide on its own, because the effects on climate change on our mental health is multifactorial. There are some direct effects where extreme temperatures, air pollution, and natural disasters directly affect our moods. We become irritable, it's hot, you become angry, your house is damaged from a flood, you're depressed. So it's just the direct effects, it's just the feeling of the weather changing around us. The indirect effects, which we've explored quite thoroughly in terms of the displacement and food insecurity, and all that strain that actually affects a person's mental health. I mean, not being able to have food for your family is just something you can't smile your way through. And then eco-anxiety is starting to become a condition that should be recognized as this chronic worry about climate change. And I don't think it's just a first world problem. I mean, if you've had your one informal shack get flooded or burnt, I mean, you're going to always be feeling anxious about this happening. So these are just the different prongs that which make mental health. And then lifestyle medicine, why we're here. So for those of you that don't know what lifestyle medicine is, so lifestyle medicine is it's is an evidence-based approach to preventing, treating, and even reversing diseases by replacing unhealthy behavior with positive ones. So we talk about the 6 pillars of lifestyle medicine. We recognize that addressing health within these 6 pillars has actually been shown through evidence to manage health. So we talk about healthful eating, going towards a whole food, plant predominant eating pattern. We speak about increases in physical activity and reduced sedentary activities. We also speak about managing stress strategies, developing strategies to manage stress using mindfulness-based stress reduction techniques, which I'll go into a little bit of that more with you. Lifestyle medicine recognizes that social connection is relevant to health. So we talk about positive psychology interventions and having healthy relationships with people around you. Sleep, as I addressed again earlier in the presentation with heat stress, sleep has so many confounding effects to weight gain, to blood pressure, mental health. So sleep and protecting sleep is something that is an important pillar of lifestyle medicine. And then we speak about avoiding risky substances. Typically we talk about alcohol and cigarette use, but in this context I want us to think about risky substances more as litter. That is something that is done so cavalierly, and it is a major contribution to climate change. So yes, climate change, we can see it as a threat to lifestyle medicine. So in terms of nutrition, climate change threatens crops. When we have these droughts, food becomes expensive. I think they've just said recently Johannesburg is the most expensive town to buy food in the country. So it makes it that if you want to tell somebody to have healthy food, have some salads or whatever, they don't have a fridge to keep the salad cool in this weather. It's too expensive because cold chain is a major issue. When you do buy food that is not like some of the research that I did with the diabetes, when people were asked why they don't eat fruits and vegetables, and the people in peri-urban South Africans would say that not only is the quality of fruits and vegetables that are sold in peri-urban qualities poor, it is also very expensive. So it just becomes this double challenge because of that lack of cold chain. Physical activity, I think we all can attest to that. When it's hot or dusty or whatever, it's just really not conducive for you to go and exercise and take care of yourself. So that's a direct impact. The restorative sleep. These hotter nights really do impact your ability to fall asleep and to get a good quality of sleep, and therefore subsequently affect health outcomes. Stress management. As I said before, with mental health, the rise of eco-anxiety and the trauma from climate disaster is a significant mental health burden. The social connection aspect, when people are getting displaced from their homes and they've lost their families, and all this community that gets affected by climate change and natural disasters is a direct threat to lifestyle medicine. And then I've got a little image here of the goats eating the plastic bottles. If you drive into Barra any day, you will find this the roads are littered with this waste, and then these goats eating it. And I always wonder, is anyone eating those goats? And how is this actually affecting? How's it affecting them? Yeah. So that's it. So we move on to, instead of all the doom and gloom, lifestyle medicine is all about coming up with solutions. And so the planetary health is considered the new paradigm for a new era. Adaptation. At the end of the day, if we want to evolve, this is where we are. Climate change is here, it's happening, and we need to adapt and we need to build resilience. And so it comes in planetary health. Planetary health is a solutions-orientated, transdisciplinary field that seeks to find and implement win-win actions and solutions for the health of both natural systems and the people. So I found this to be a really refreshing take on how to deal with climate change, and it's the school of planetary health, or the field of planetary health, seems to be growing quite significantly overseas. Definitely getting a lot of traction amongst the Ivy League American schools, Brown universities, encouraging everybody to do a planetary health course. But even in Africa, there's the Eastern African Hub of Planetary Health, where they're also, our climate change issues are completely different in the global South versus the global West. So yes, it's a refreshing look. So I wanted to share with you this case study of a really wonderful planetary health innovation in Senegal, which won Frontier Planet Prize Awards for $1 million francs to continue this research. So I hope it inspires us a little bit to think of some solutions. So let's give you a little bit of background and context. So we are in the Diama Dam in Senegal. This is a dam that was created for irrigation. They started building up agriculture in this area in Senegal, and as an unintended consequence of the use of fertilizers, there became an overgrowth of this particular vegetation or weed that caused for there to be a blockage of the waterways from the dams towards the community, but more importantly, caused for there to be growth of these snails. So I'm going to go back just again, another lecture, infectious disease lecture. Schistosomiasis, some of you might know it as bilharzia. It is a condition which so this is the life cycle of schistosomiasis. I don't know how to use this pointer, but basically you find the parasite is, the vector of the parasite is the snail, and what will happen is people that are engaged in the water from whether they're swimming or eating or drinking that water, the parasite will enter through their skin, and it can either affect their gut or their bladder. And some of the major long-term consequences, despite that there are treatments for schistosomiasis, you can get recurrent infection, and the long-term consequences of that would be bladder cancer and portal hypertension, which is a major cause of liver failure. So the health impact of schistosomiasis is very important. And so what they started noticing was that ever since there was this excess in vegetation, there were more incidents of bilharzia in these areas. So the hypothesis of this study was that if they could remove this vegetation, could we reduce the bilharzia infections? So the objection was to whether removing the aquatic plants can lower infection rates and improve water flow, to investigate the potential to convert the cleared vegetation into compost or livestock feed as a sustainable economic incentive. And then the third objective for scalability was to utilize satellite imagery to identify additional snail habitats and enable broader implementation of the strategy. So in this, there was a 3-year study. They over across 16 villages in Senegal. So there was 8 intervention and 8 control, and the data that was tracked as a primary objective was the rates of infection in school children, and then obviously then secondary was snail population and the amount of vegetation removed. Then, as we said, there was an economic test to this, and so the cleared vegetation was used to make compost for the planting of crops. So I think they did red peppers and onions, and also as directly as feed for the livestock, the sheep especially. And then they calculated the benefits to cost ratios of that. So great results out of the study. So there were 1.46 times lower schistosomiasis infection rates in school children, and an 8-fold reduction in snail abundance. There was also a lot of financial benefit that was recognized. As compost, the benefit was the cost ratio was up to 4, and as livestock feed, it was much cheaper and also had less greenhouse gas emissions in comparison to the traditional fertilizer that had been used. Also from the environment and the community, it also inspired togetherness of the community. People felt like they were improving their homes, and that was really good, and improved the quality of local biodiversity. Scalability. The team was able to show that using satellite imagery, this is not just an isolated event. We can do. So, as I said, planetary health is our call to action. It's an umbrella for us to start making the kind of changes that need to happen. We're all in different industries of health or economics or robotics or whatever it is, and we can all work together in this transdisciplinary field to contribute to the health of the planet. So here are some just simple call to actions. Maybe you can pick one of them for today that you can lead this fight towards in planetary health here in this country. So create the platform for collaboration for planetary health. I think this is a great platform, and we thank Pam for arranging this. To raise public awareness on planetary health challenges. Collaborate in research activities. I think at this point in time, there's not a lot of research, and the problem is different in Africa versus in other parts of the world. So the more research that we can get done, it's at least a very good first step. Cooperate and innovate with indigenous communities. A lot of people have their own solutions for their own problems, and it would also be a solution for creating employment in Africa, which is expected to, by 2100, have 4.4 billion people in Africa. So now is the time to create solutions with the manpower of people that we have. Develop educational curriculum and learning resources for transformation. I think if this stuff got into our curriculum, more people would have more interest in contributing to planetary health. We might have very, very good solutions ahead of us. And then finally, we're going to prescribe lifestyle medicine for planetary health. So so what is the lifestyle medicine prescription for planetary health? So I've put there on the side goal setting, SMART goals. So in lifestyle medicine, we recognize that lifestyle is what contributes to chronic disease, and in that is not an overnight thing. So, even making changes using lifestyle medicine can also not be an overnight thing. And I feel like that resonates very well with climate change, in that this climate problem began a long time ago, and it's not going to take overnight to make changes. So the small changes we can, using the SMART goals, being specific, measurable, attainable, realistic, time-bound goals, will be able to make us make these changes. So I'm going to give us some simple lifestyle medicine SMART goal prescriptions that you can share with yourselves or with your patients going forward. So in terms of diet, champion the affordable, local, plant-predominant diets that are healthier for you and the planet. So I'm really looking forward to Mbali's presentation to hear more about the indigenous crops that we should be looking into eating. Physical activity, we really want to promote active transports like walking and cycling. And I know there's a lot of excuses that it's not safe and it's too hot and whatever, but any impact counts. I mean, if the Checkers really is 100, and that's for me, there's a Checkers 500 kilometers down the road, and I always get in the car, but I think from now on, it doesn't make sense. Take that walk and make that small difference. Stress, so acknowledge climate anxiety. Know that it exists. It's real. And when lifestyle medicine, we talk about coping mechanisms and not really running away from stress. So one of the big ways of managing stress is prescribing time in nature as stress reduction. So there's been very, very good evidence that shows that they call them the phytochemicals, so the nutrients that the trees secrete from their leaves, has active benefits in reducing inflammation, protecting you against viral illnesses, and reducing stress levels for up until a week after a walk in the park. So if you are from Joburg, get your patients to go into some of our lovely parks. I mean, South Africa is beautiful for our biodiversity, and there are tons of beautiful national SANParks does a great job. Get your patients out, explore nature, and spend time in nature. It is a powerful, powerful stress reduction tool, and it's achievable in realistic. Sleep. So it's hot. We've seen the urban heat island effect is real. So I think when your patients are coming here telling you about sleep, we should get into talking to them about sleep hygiene, about making sure that the room is cooler when you're going into bed. Taking a shower before bed can actually lower your central core temperature and make it easier for you to fall asleep as well in terms of heat. Also cleaning up other sleep hygiene effects, like not watching TV before going to bed. Those will be other little things that will help you manage the stress of the heat stress that comes with sleep. And social connection, I've put it here a nice little, because I think it covers both the connections and substances, of people collecting litter. It's something that used to happen a lot when I was still in primary school. I don't know if it's still happening anymore, but litter drives, you know. It's a really simple way that one could even do with their own family. Go for a walk on a Sunday and pick up the litter in your own area. It's a direct impact on climate change and a direct impact on social connection, spending that time together and trying to make your home and your life, your place look good. So thank you very much, everybody, for listening to my presentation about health and lifestyle medicine. I've put here a little poster about South African Lifestyle Medicine Association. You've got some cards from us in your goodie bag with the QR code directly to our website. So we as the South African Lifestyle Medicine Association, we are basically advocates for lifestyle medicine. And we are a growing community. We're about 4 or 5 years in, and we're just a group of like-minded healthcare professionals, doctors, pharmacists, dietitian, anybody who's a healthcare professional is invited to join South African Lifestyle Medicine Association. We offer monthly webinars and bi-monthly journal clubs to offer CPD points. We get really exciting speakers. We also do a lot of social connecting. So we have lots of member engagement things. So we've done a forest walk, we've done one in Knysna, and we did one in Gauteng here at the Wilds a couple of months ago. We do cook shops. We're planning an event very soon. So yeah, so please join us at South African Lifestyle Medicine Association, and let's be the prescription for resilience.
Thanks so much for that. It was really insightful. I think it's really nice to bring in the lifestyle medicine aspect into the conversation, and I love that both you and Mafoko really gave practical tools of what we can do and how to get involved. So thanks so much. We'll open the floor for some questions. So once again, if you have any questions, please just raise your hands, and then we can answer them. Any questions? I saw a lot of writing.
Yeah,
okay.
A lot of writing. Just looking at the opportunities, you mentioned two things. The first one is when you deal with patients and you encourage them to eat a plant-based diet, they talk about affordability and so on. And my question is, in your setting, how do you best support them? Because there are instances where we are used as professionals just giving them counseling cards with messages, but not giving them practical tools. There's even space where they will always say we don't have space. Practical tools would be to encourage them to do urban or vertical planting. Do you do that? And how practical can you be in a hospital setting where you can actually showcase and give them tools? So I'm just asking myself, how practical can you be beyond just education? The second one, I'm excited that you have this number of activities, right, that you engage in as an association. Yeah. So one of the initiative you could consider, considering that you talk of heat stroke, we have opportunities of is Abba Week or like Planetary. So that could be some of the initiatives that you engage in, and your stakeholders or even your patients, you bring them in, and you choose sites where you know that there's deficiency in trees, and then you go plant them, right? But also give them starter packs. When you do your cooking demonstration, give them starter packs for seeds or seedlings where they can go back and plant some of the things that we're encouraging, whether it's drought resistant and so on. Those are some of the thoughts. to say, as professionals, let's not just give education, give some practical tools. I've been there, I've just been giving education, but it doesn't work.
Yeah, I think that, I really like what you're saying about that in terms of practical tools. As I said, lifestyle medicine as a concept is about 20 years old. It's not actually a specialty. It's an approach, and we wish it would get into medical schools, into medical school curriculums. As providing this advice practically as somebody who's starting up their own lifestyle medicine practice, it is extremely challenging. It's a lot of, and when you do, so lifestyle medicine also includes a diploma, which South Africa, we also have one now. But some of the major teaching is around change behavior and the psychology of change behavior. So it's, unfortunately, you can't look at lifestyle as an isolated eat like this or sleep like this. It's a continuous process of behavior change. So it's extremely challenging, I'll say that. South African Lifestyle Medicine Association is healthcare worker facing, and I think it's important for us to be healthcare worker facing at this point, because we need to get the word out amongst ourselves and create that ingenuity and that developing of innovation amongst ourselves as healthcare providers who have had their experiences. You know, you've had your experience of giving out education and you've realized it is not working. Engaging each other on a platform like the South African Lifestyle Medicine Association, which is still as new as it is I think a refreshing place for people to put their ideas out there and get things to actually happen. So, I mean, I would love to chat to you more about this tree planting initiative. We also have Leonie in the audience. And Leonie, please, I just want to say treaty, but I can't remember the whole name, I just went blank. But yeah, do you want to just tell us about the association that you
Yes. So I'm a team member of the South African branch of the Global Plant-Based Treaty. So we are aligned with the Paris Agreement, and we are a grassroots movement focusing on food systems and the impact of food systems on planetary health. And I know one of the initiatives that they do focus on is also with assisting communities with planting trees and that kind of thing. So it will be great. In your little goodie bags there wasn't enough to go around, but there is a little pamphlet on the plant-based treaty, and we really encourage people to endorse the plant-based treaty, and there's a huge amount of resources on the site as well, and what they are doing globally to create awareness and how everybody can get involved and be just to endorse it and make a little change wherever we are. So plant-based treaty.
Yeah, but I'd love to chat to you about the trees. Get some stuff going.
Thank you very much for an exciting presentation. My name is Graham and I'm the Deputy CEO here at FD. My quick question to you is, to what extent do you engage with people with indigenous knowledge particularly around diet? To kind of get that, because if you look at the lifestyle now and the diet that we're consuming, compared to what we used to, what our great grandparents used to consume, there may be some value there in kind of like promoting that indigenous knowledge and integrating that into what we know now.
Yeah, 100%. So my background where I did my MBA was in diabetes self-management. So I looked at diabetes self-management behaviors that affect diabetes outcomes. So the study I did at the Eden Joseph Hospital interviewed about 200 patients, and the direct significant correlation between diet and glucose control was there. Poor diet, poor glucose control. But what I found really interesting was doing the literature review in Africa and where the issues are with food. there is definitely a lot of, I would say the challenge of food is multifactorial. There's the ignorance. People see, so you'll actually notice compared to the Western world, where people of lower socioeconomic status are at higher risk of metabolic diseases because of diet and nutrition. It's the opposite here. So the more people that are getting wealthier and transitioning from a sort of rural to more progressive lifestyle, they are now changing towards going towards that less healthier eating style. And so that is something that is unique to this country, and a different approach that we might need to take in terms of who do we address this nutrition advice to. Obviously, when it comes to the poorer people at this point in time, the reality is cold chain is an issue, and addressing food as we know it is a problem. So I'm, like I said, really excited to hear what Mbali is going to suggest about what we can suggest to people. But the food that is accessible and is affordable is unfortunately creating a major impact on the climate footprint, you know. Even when it comes to the pet peeve of mine is the chicken and the AGOA deal, where we're getting this chicken that is produced in this really environmentally unfriendly practice from the Western world, and we're getting it across here in South Africa, and it's being affordable for our population, but it's making them sick. So I think the answer is, let's hear what we hear about the indigenous approaches. It's something I would love to have an answer to, but I think the problem is different, and we need to approach it as such. Yeah.
Morning everyone, hi, I'm Janita. Thanks Dr. for an amazing presentation, and I like the lifestyle medicine stuff. I actually recently did a very short course on lifestyle medicine, 3 courses or so, and I've been trying to implement it in I'm currently locoming for a GP, and you try to implement it with patients. And I just want to ask a quick question. Don't you also think it kind of boils out to taking responsibility more of, because we live by this that I have a right, but we forget that we have a responsibility, right? So for example, we can say, right, we've helped you diagnose that you have diabetes. Okay, this is the ways of getting things done, and maybe this is how you can take responsibility. But they would rather pop the pills or take the injection than to change. And I think that also applies to what you also mentioned about our quadruple burden. So for example, if we take HIV, AIDS, TB, mother and child mortality, I think it also kind of burns us to the point of, I have a right, for example, to have sexual intercourse, but if we're getting our responsibility to condomize and to prevent further transmission, further pregnancy, and it's become such a thing that maybe now it's a bit more of a norm where we're okay with our youngsters engaging in sexual intercourse and getting pregnant early, 100% right, your body, your right, but then we're not realizing the impact that it's having afterwards, because you're getting kids at the age of 13, 14, and I've seen it. I worked during my ComServe, I worked in both obs-gynae and peds, and I saw both sides of the fact of, for example, a young mom coming not ready to physiologically push the baby out, leading to maybe HIE and so forth, hypoxic death. Or rather at the age of 13, 14 and having a Caesar, then they're going to come later on with future pregnancies, not able to have a push, have natural delivery, having further Caesars, leading to more adhesions, more complications, and a higher chance of like a placenta being morbidly adherent, right? And I think that's what's also leading to our higher mortality rates, or our higher rates of child and maternal mortality. And even when you come to things of, for example, even patients with diabetes, you tell them, listen, here you have, we're giving you the meds at a free level at the hospitals, but they're not coming back to take the meds. They'd rather come in DKA and say, oh no, I forgot to take, I don't want to change. So I think I don't know, maybe for me it feels like more of a, how do we get them to accept that responsibility that all of us, we're all at some point guilty of not taking responsibility for something in our lives, or helping to contribute to that change. So even like, how do we then get every single one of us, not only the people at the high level, the courts, the laws and stuff, to take responsibility for that climate change, because all of this adds to it, because more births, more burden on the environment globally. And so how do we then get every single one of us to accept that responsibility that we have a role to play in our environment, in our climate, in improving our own health? So how do we do that?
That's a very philosophical and esoteric kind of question, but I think I have a little bit of an answer. So I'll tell you one of the stats that they said about lifestyle medicine, and they say a healthcare worker that is more likely to that practices physical activity or eating healthy is more likely to prescribe it. So as I said earlier, we need to talk about SMART goals. We need to do what is realistic and what is achievable. And I think one place to start is with yourself. If we can get more of us as healthcare workers getting actively involved in living lives within the 6 pillars of lifestyle medicine, understanding your patient becomes slightly different. You're able to meet them at the level where they are. Once again, if you really are interested, I would recommend doing the diploma, because that training on change behavior is really where it's at. You'll find that people are at different stages of change, and so therefore the solution is not a one-size-fits-all. Some people are at the pre-contemplative phase where they don't even realize that smoking is why their blood pressure is high. They just hear you saying stop smoking, and so there's no link to that, so there's no relevance to that. So my answer to you is not really much of a direct answer, other than like what you said, take it back in and take that personal responsibility back to yourself and see how you can live within these 6 pillars. And in that personal experience, I think you will actually see a difference in how you engage people. Yeah. So I think it's time. Sorry.
Thanks so much for the engagement. I know there are some questions, so please feel free to ask your questions in the break or at the end. I just don't want anyone's blood sugar levels to go down. So thanks very much. Let's give Dr. Okay, so I think we can break now until 25 to